Listo, doctor, ya empezó la transmisión.
Okay. Buenas tardes. Okay, sorry about all this situation. We are late. We are so happy. Hello, everybody. Welcome to the seminar of the IMD. I just want to tell you that I'm really happy to present our speaker today, Professor Chrit Moonen. Dr. Moonen is one of the truly best known leaders in MR now. And I just want to share with you really fast because we have run late now. Chrit started his career, his PhD, he studied at the Agricultural University in Wageningen in the Netherlands. And then he moved, he stayed there for working for a time, and then he moved to the US, to the University of Davis, California and Davis, as a visiting research. But most importantly, in 1987 to 1996, he was the director of the in vivo NMR Center at NIH. To all of us that have something to do with MR, can notice immediately that within those years is around 1989, 1990, the decade of the brain and NIH, and most importantly, the come to age of fMRI. So for any of us who has worked in MR, Chrit Moonen's Blue Book, Moonen and Bandettini's book is a book that we know. And from 97 to 2011, Chrit moved back to France, to Europe, in France, and he was the director of research for the CNRS in France. He was at the time the director of the Laboratory of Molecular and Functional Imaging from Physiology to Therapy, and physically at the University of Bordeaux, University of Bordeaux, now he's since 2011, he's a full professor of at the imaging division in the University of Medical Center Utrecht at the Netherlands. Well, I just want to share with you a couple of more things. Chrit has 15 patents of MR. Many of them. He wrote a paper in Science, his first author, about functional magnetic resonance imaging in medicine and physiology in Science in 1990, which I don't need to tell you that is seminal. And then just continuing with the idea, he had another one about 3D fMRI imaging in Proceedings of the National Academy of Science, the USA, which obviously is probably one of, if not the first, well, yeah, I mean, it's the first in 3D fMRI techniques. At that time, we used to work in a 1.5 Tesla machine. And well, he has been in, among other many things. He was the president of ISMRM, president, founder of the European Society for Molecular Imaging. He has done many things, and today he's going to be talking to us about molecular imaging. Well, this is fMRI guided ultrasound temperature imaging, and I am really happy. I'm very sorry that we are starting late. So, without more, please, Chrit, we are listening. Thank you.
Well, thank you, Fernando, for this really nice introduction, and thank you all for your patience while working on this, getting these hiccups removed. Okay, let me see if I can share my screen and start my lecture on, let me see on where I get this. I think it's there. Let me see one moment. I I don't see my screen on this. I'll get there, just a moment. Okay. Go there and then in presentation mode. That should be number. Let me just see on it. Should go to number 1. Okay, can you see this?
Yes.
Do you have my screen? Okay.
Yes, it's
Good.
coming.
Then let's start. So so this presentation will be on the non-invasive on precision medicine with image-guided therapies. And again, I'm now working, as Fernando said, at University Medical Center in the Netherlands. There will be, I will present on 2 non-invasive therapies with external beams, so completely non-invasive therapies. One is MR-guided radiotherapy, where the therapy is done with linear accelerator, with using photons, with electromagnetic waves. And the other one, it will be on MR-guided for high-intensity focused ultrasound, where we will work with pressure waves, mechanical waves that do the therapy. Both are MR-guided, and so my presentation will be a lot on the guidance by MRI. Why do we want those techniques? Because radiotherapy, of course, is an old technique, is already well established in the clinic, less so for high-intensity focused ultrasound. But why do we want to have them MR-guided, MRI-guided? Well, MRI, as most of you will know, offers superb soft tissue visualization. And these are 2 examples how radiotherapists work in the planning of their therapy. They align all these things, what you see here, the primary tumor, the gross tumor volume in red here. They align then also the clinical target volume in blue, that encompasses a larger area, and the organs at risk, OAR, like in this case, the bladder and the rectum. On the lower right, you can see that, for example, here the pathological lymph nodes that are well delineated on the MRI, as well as the organs at risk. So here you can see already why MRI gives superb contrast. It's already used for the planning, but it's not being used during the therapy itself. Radiotherapy, of course, it works. The action mechanism is primarily DNA damage. It is standard of care for many types of cancer. It uses high precision treatment, gamma knife, linear accelerator, and proton beam, even carbon beam. And the current pre-planning is image-guided, so with the gross tumor volume, abbreviated by GTV, clinical target volume CTV, and organ at risk at OAR. Until recently, the treatment itself is not image-guided. So often this planning is only done once, and then you have a whole series of sessions in which, during which there is no imaging done while the tumor is hopefully shrinking. And this is, of course, that's of course what we would like to change by doing this MRI guided, where each therapy is guided by MRI. Now, how does this work? Because MR-guided radiotherapy is not an easy thing. This MR-Linac the product is sold by Elekta together with Philips MRI, and it's recently, since a few years now, on the market. It's FDA approved. It has CE label as well, and this is by no means a standard MRI. You can see here the accelerator on this large metallic structure, and it's firing through the MR system. Now and here you see the patient is then lying here on the table in the MR system. Overall, this MR is almost a standard 1.5 Tesla MR system. It is a bit special in the sense that the design of the primary coils here is done in such a way that there is zero magnetic field in this rotating large metallic structure. And that's of course needed because otherwise you would have a change in magnetic field all the time. If this is zero, perfectly zero, then there is no effect upon a rotating metallic structure. So this is in very short the principles of the hardware of this MR-guided LINAC system, or the Unity as it is called now. Again, this is a system that is now on the market and is now already approved for quite a few applications. The real-time image guidance, where you also look at motion structures and so on, where at motion of internal organs, that is still being worked on quite a bit. It's not yet completely in approved technology, but it's getting there. High-intensity focused ultrasound is not the primary action, is not DNA damage like it is in radiotherapy. There are many different action mechanisms. Often it's thermal ablation, so it's increasing the temperature until really the tissue dies off. There is a rapid expansion of applications in oncology and neurology. It has FDA and CE approval to treat uterine fibroids, prostate cancer. Prostate cancer, that's, by the way, the application where most patients have been treated. Pain from bone metastasis, essential tremor, Parkinson's. There's several clinical research milestones, like the first clinical non-invasive opening of the blood-brain barrier for drug delivery, and I'll get to that later on. It's a recent disruptive technology with limited reimbursement for the HIFU procedures as of yet. It can be guided by ultrasound imaging, like most of these initial applications on prostate cancer. They were all ultrasound guided, but MR guidance is actually becoming quite important. If you want to have an update on where the technology stands, there is a website on the American Focused Ultrasound Foundation. This website, it gives an excellent overview on where the technology stands and the applications. Now, if you look here at the hardware, then this is a standard 1.5 Tesla MR system. Inside the bed, that's where the modification is. There is a transducer that is an ultrasound transducer that is embedded in the table top, and you can see this here enlarged on the bottom. This transducer is almost as big as a hand, and it's not a single transmitter, but it's in this case 256 transmitters. They are all firing, and they're in the focus. And all these bundles, these beams are coming together in the focal point. It's very much similar principles as an optical lens, and you bring them together in the focal point. The physical principles are very much the same, with, of course, the difference here that we are talking about mechanical waves. Now, what are the dimensions of this focal point? They are of the order of 1 by 1 millimeter in this plane, parallel to the transmitter, and in this plane maybe 6 or 7 millimeter. That gives you an idea of the dimensions. Now, MRI is very similar, as I mentioned before, in radiotherapy. It's used for anatomy. In this case, however, we can also use, if we raise the temperature, we can also use the MRI for temperature mapping. And that's, of course, very useful in real time, seeing how the temperature is being raised, because that will determine the efficacy of the treatment. And then there is this computer that controls both the MRI and the firing of the transducer for position and power control. That's in very short what the hardware and the software does. Now, the technology is that in the image guidance and the applications, ablation, local drug delivery, immunotherapy that I will do later on. I will mostly talk about high intensity focused ultrasound, abbreviated as HIFU, but I will every time as I can reach back to MR guided radiotherapy, because radiotherapy is of course the more established technology in the clinic. Now, the common thing in the MR guidance is that you use the MR for the planning, and the planning that I started with that, then the real-time guidance during therapy delivery and the evaluation of therapy. Now, planning, I already done something, covered to some extent. You want to use rapid 3D MRI, both for the target definition and the organs at risk. You also would like to have a motion description. That motion description you would also like to do in real time. And because of course, if the internal organ or is your target, it's like, for example, a tumor is moving, then you want to know where your target is at any time. Now, this what you see here is real-time image processing of MRI. These are echoplanar imaging, and they are actually treated, processed in real time. You can see this here in this vector field, that this indicates this with these little arrows how each part in that image is moving. In this image in the plane, and you would like, of course, to have multiplanar or 3D. But for example, here, if you look at the pancreas, then this here, this plot on the right shows you how the pancreas is, the pancreas head is moving during the respiratory cycle. This is mostly top down, but also there is a little bit of left right, and you can see here with very high precision, and that sub-millimeter precision, that you can do this in real time. This is within, let's say, 100 milliseconds, that after the finishing of the echoplanar imaging, you have these data. So this technology is 10 years old. So this really can be done, and with the progress of the graphic cards, as in fast computer in the game, in the computers that are used for gaming, you can really do this kind of things quite easily. Now, of course, this displacement of the target and the organs at risk for both the MR-guided radiotherapy and MR HIFU image registration are really issues. Update of the radiation dose for radiation therapy and the adaptation of the treatment plan. These are all still very much in development. They are not really standard of care as of the moment, even for radiotherapy and MR HIFU. But since the technology is really very, very similar, we are working at Utrecht very closely together with the radiotherapy department. In the radiotherapy, it's the same department. We are actually within the same department, imaging and oncology. The MR Linac that I talked about, the MR guided radiotherapy, is invented at Utrecht, and it is now, as I mentioned before, is now brought on the market by Elekta together with Philips. Now, going back to high intensity focused ultrasound, this is a clinical trial that we did on breast cancer, real-time temperature mapping. You can see here the two planes, the coronal and the sagittal plane, and you can see here the evolution of the temperature. This is the tumor here, and you can see the temperature rise in this while we are firing, and you can see in the hottest point that we are reaching about 50 degrees. We would like to go for ablation to go a bit higher, something like 55 degrees for a few seconds is sufficient to really bring necrosis or apoptosis. So this was an initial clinical trial, a phase 1 clinical trial that was actually finished something like 6-7 years ago. that we are trying to follow up now, but they're sort of hindered by the COVID like everywhere. But this is the kind of technology that we can use for that. In the liver, you can also do this kind of thing. This is in the presence of physiological motion. This is preclinical work. This is in a pig liver, in a porcine, in a living pig, and you can see here the correction for the respiratory motion, and you can see here that this kind of technology leads to here the temperature rise in the focal point, in the focal region, so about 12 degrees Celsius. We are imaging at a rate of 10 Hertz, and that is sufficient that we can actually describe the temperature with about a precision of 0.3 degrees Celsius. Now, turning to, again, a HIFU application now in the brain, that is not coming from our lab. This is coming from Elias in Williamsburg in the United States. And this is on essential tremor. This is quite a debilitating disease that those people suffering from this, they cannot really hold their hands still. And for them, drinking a cup of water or eating is very difficult. Now, what the neurologist asks them to do in order to describe how serious their tremor is they ask them to stay within these lines in this figure, and you can see that how they have difficulties or staying between these two lines, and they simply cannot do it. Now, what is targeted here is this very small area in the brain here and this has its projections again on the motor circuits, and this one has to be really targeted, ablated with very high precision. And how this procedure is done, so you have. I'll show this later on. There is an ultrasound transducer covering the whole head, and they're all firing exactly towards this point. In order to be sure that this really has the right spot, they raise the temperature first to about 47 degrees, so that it's not yet lethal, but see that there is an effect. And if they are sure that this is really the proper location, it's not only an anatomical positioning, it's also a functional positioning on whether they have the right location. And then they continue with raising the temperature to 55 to 60 degrees. And so you can see this here. Where the beams are coming from every direction. There is a correction here made for the skull. That's sometimes, in some cases, a bit difficult because ultrasound does not easily cross the skull. For that reason is also that the frequency of this ultrasound beam is lowered a little bit as with respect to the previous example that I've shown you on the breast. Nevertheless, this is later on with just simply T1 is just T1 weighted image is verified that this is indeed there is a lesion exactly in the planned location, and then the patient comes out of the system and he's asked to do the same exercise here and staying within the line, and he can perfectly do it. This is an immediate effect. So just coming out of the system, giving him a bit of water or asking him to work with the spoon, you can see that the patient really can do this. This is now an FDA-approved method. It is in essential tremor. There are now many efforts to broaden this towards other Parkinson type, because Parkinson's type disease and this phenomenon, and do this. This is also getting the reimbursement is also more and more is it accepted by the insurance companies. So this is a real success story, and it's done with the instrumentation is developed by by Insightec, Israeli company. They previously worked with GE equipment, but now also work with Siemens and pretty soon as well for Philips equipment, MRI equipment. It brings me to this application was on ablation and was now moving to image-guided drug delivery. Image-guided drug delivery can be done by many different means. They're all sometimes also already in the clinic. This is, for example, image-guided transcatheter or transneedle local delivery, ultrasound-guided or CT-guided, gene delivery via stem cells, immune cells, gene carrier, image-guided drug and gene activation, photo-activated drug delivery and activation. They are all, and there are many reports on this. This first one, by the way, is almost standardly done in the clinic. Image-guided delivery from targeted drug and gene nanocarriers. What I will mostly concentrate here in my talk is ultrasound-triggered opening of drug nanocarriers and ultrasound-triggered opening of biological carriers, cell membranes or blood-brain barrier. This is an early preclinical, it's from a rat. The challenge indicating well the challenge of drug delivery over the blood-brain barrier. This is a whole body autoradiogram of a mouse. There's radio-labeled histamine, which is a very small molecule. You can see that the darker the intensity, here the more dark it is, the more of the histamine is present. And you can see this histamine actually goes almost everywhere over the body, except in the brain and the spinal cord. Shows well that the blood-brain barrier, that there is this small, like drug-like molecule does not get over the blood-brain barrier at all. Now, high-focused ultrasound has many bioeffects that actually can use these shear forces in combination with microbubbles. These microbubbles, by the way, they're not only used for good for champagne, but they also can be very well used they are used microbubbles in ultrasound imaging, for example, in the heart, to looking at physiology of the heart. But they can be used in permeability enhancement in cells, as known as a sonoporation effect. Widened intracellular spaces, the increased extravasation through the enhanced permeability and retention effect, and diffusions through the interstitium, and absorption of ultrasound energy, where you don't raise the temperature high enough for ablation, but enough for hyperthermia, that leads to increased perfusion, increased EPR, and increased oxygenation. Again, there are many papers that actually you can look up at these effects. What I want to cover briefly in my presentation is ultrasound-triggered image-guided drug delivery for getting drugs over the blood-brain barrier, hyperthermia and extravasation of drugs and nanocarriers, getting drugs over the cell membrane, sonoporation, and intravascular drug release from temperature-sensitive carriers. Now, first, let me go again to the brain. A good 10 years ago, there was an initial publication of the team from Claire, Nathan McDonald, then working at Harvard at Boston. Kullervo moved then later on to Toronto in Canada, showing that this is on a rat brain. There is a low intensity pulsed high Fu exposure combined with ultrasound contrast agents. So these microbubbles, they are injected intravenously, so they travel all over the body. So in all of the vein and all of the vasculature here, there are microbubbles. This is where you target the beam of the focused ultrasound. And then later on, when you have done this procedure, then you add an MR contrast agent. The MR contrast agent in the healthy brain, in this case the rabbit brain, does not go over the blood-brain barrier. And here you can see the T1 effect, showing that the MR contrast agent has crossed the blood-brain barrier and nowhere else. So you can see that you actually, doing this procedure, have opened locally the blood-brain barrier. Now, if there is an implanted tumor, in this case a rat MRI, then sometimes you see very weak opening of the blood-brain barrier. And that's also what you observe clinically sometimes. So opening of the blood-brain barrier. But if you then do this procedure and you do this whole area in there, that you can see the blood-brain barrier opening up much more. Now, this of course gives a tremendous opportunity of delivering drugs to the brain. And this has been the major impediment for basically all brain diseases, whether you're talking about brain tumors, Alzheimer's disease, Parkinson's disease. They are almost all brain diseases are hampered by this blood-brain barrier that blocks all macromolecules and 95% of all of known drugs. There are only a few exceptions there, like, so for example, the epilepsy drugs that are that do cross the blood-brain barrier, but there are few. Now, there is preclinical work, again, this dates from already from 10 years ago, from a team from Paris, Marty and colleagues, who looked at this in more detail about, so when, and they did in rats, every time the same, exactly the same location that they did this procedure, hitting this location with the ultrasound beam in the presence of microbubbles that are everywhere in the vasculature, and then adding, and then after a given time, this is the time elapsed between the blood-brain barrier opening and the intravenous contrast injection. And if you do that, and this is the normalized gadolinium concentration. So if you vary the time after this, for example, in these red blocks, this is the MR contrast agent was a gadolinium chelate, about 4 nanometers. So this is already a bit of a larger MR contrast agent. Then you can see that you can still get the normalized gadolinium concentration, and that is actually decreasing, and upon, let's say, 3 hours, then you cannot get this in the brain parenchyma anymore. If you look at this, if you what this logarithmic curve, then you see a half time of about 1 hour. That means that you have about 1 hour the time to get 4 nanometers drug over the blood-brain barrier. If you look at smaller MR contrast agent, this DOTA-RAM is a 1 nanometer diameter contrast agent, then you can see this kind of data characterized by a half time of 4 hours. That means if you open the blood-brain barrier in this way, then you have about 4 hours time to get drugs with this diameter over the blood-brain barrier. This depends a bit on how what pressure level you're putting there and for how long. So this depends really on the characteristics of the focused ultrasound procedure, and of course as well this does depend on the characterization of the microbubbles, on what type of microbubbles and how they behave. Also, HIFU-mediated antibody has been shown to already in a publication more than 10 years ago that this actually works. On the right-hand side, you can see with this coloring that actually antibody was delivered into the brain. And this, of course, raises the prospects. Can one do this type of thing? For example, in Alzheimer's disease, you maybe heard of this new drug by Biogen, so for Alzheimer's disease. So whether the drug really gets into the brain at sufficient level is quite a controversial point, and perhaps this kind of technologies could help in the future. Where do we stand with this technology? Again, most of this has been has been many labs are involved in the preclinical work. In the clinical trials is mostly, as of the moment, it was done in Toronto. There's a phase 1 clinical trial for Alzheimer, a phase 1 clinical trial of gliomas, and a phase 1 clinical trial in metastasis of breast cancer in brain. And from this last one, there was a recent Science Translational Medicine paper from Meng and colleagues from Toronto on MR-guided focused ultrasound, delivery of trastuzumab to HER2 positive brain metastasis. And you can see here that this really does work on this. In this, you can see here on the different patients that were tested. And this kind of technology is a real breakthrough. Hopefully, this is, of course, early phase clinical trial. It has to be proven in large clinical trials. But nevertheless, this kind of technology is a real big step forward in getting large drugs to the brain. The challenge on drug delivery to tumors overall, not only in the brain. I've shown you previously this one example of this histamine. This is a typical. If you look at doxorubicin, which is one of the standard conventional chemotherapeutic drugs. If you look at if you inject this in mice, and in mice that have a tumor implanted in the leg, then you can see that this from this already quite more than 20 years old paper that this drug doxorubicin is really getting everywhere, lung, liver, and the heart. And compared to that, actually, much less is actually reaching the tumor where you want to get it. And the dose limiting concentration is mainly determined by the toxicity on the heart. So this is a very, very serious problem in chemotherapy using this drug. Can we do something with with other technologies, as what I mentioned previously with the microbubbles? Hyperthermia and extravasation. This is from a paper from Kong and colleagues that are fluorescent images of tumor tissue, human ovarian carcinoma implanted in nude mouse, and images obtained after 60 minutes at exposure at those temperatures that are indicated here. And you can see this is 100 nanometer rhodamine labeled liposomes. So this rhodamine is what you're seeing here in these images, and you can see that the higher the temperature gets, and it is 41 to 45 degrees, that is considered hypothermia temperatures. You can see that there is much more of these liposomes that are getting extravasated. So this temperature in itself is already doing quite a bit towards increasing extravasation. That is getting over the transported from the vasculature to the tissue. Now, getting the drugs over the cell membranes can be very important if your target is intracellular. There are many examples in the literature showing that this really works, and there is an overview from Lentaker and colleagues in Advanced Drug Delivery Reviews that shows a bit what kind of mechanisms can be used here. Next to the temperature, what I mentioned before, we have this micro bubbles that can actually cavitating bubbles, these mechanical effects that actually can open up, simply make small holes in the membrane where you can get calcium in. Especially calcium seems to be a very important trigger here, that calcium itself can trigger endocytosis, that sometimes drugs get in directly, but also sometimes they get in via enhanced endocytosis triggered by calcium. They can also, you can actin rearrangement, so the cellular skeleton. So in these bubbles that actually can rearrange, and in this process of repairing this skeleton, you can also transport drugs. And then you have this modulation of ion channels that also have its effect on the reactive oxygen species that can also trigger these pore formations. So there are many different mechanisms, and depending on how you do the cavitation and what molecules you have present, you can actually favor different mechanisms. This kind of technology is also slowly entering the clinic, and this one is an initial publication on pancreas cancer, this ultrasound and microbubbles for drug delivery. So this was normally these patients are getting gemcitabine, that's the standard drug, is infused intravenously. You can, in this case, what these Dinseski and colleagues did, that's a Norwegian study. They used clinically approved microbubbles called SonarView from Bracco, clinical ultrasound imaging equipment, and microbubbles injected intravenously in 0.5 milliliters every 3.5 minutes. And this is the standard survival curve here. And this is what they got in these first 10 patients. So, of course, this is only a first phase 1, so it has to be shown that this can be repeated. But nevertheless, these are intriguing results, positive results that this actually might work. Intravascular drug release from temperature-sensitive carriers. That's also a methodology that was actually introduced by Duke University, and actually the company Celsion actually developed Thermodox, and this is a doxorubicin containing liposome, but a liposome that is temperature sensitive. So this liposome is closed when it at body temperature at 37 degrees. If you bring the temperature to hyperthermic temperature, then actually it opens up and the doxorubicin gets out. This was in a study in Rotterdam, Mansour et al. They used this in over time in a window chamber in a mouse model, and with free doxorubicin. Doxorubicin is fluorescent, so you can actually track it. You can see doxorubicin mostly in the vasculature. If you do hyperthermia combined with doxorubicin, there is a bit more of the doxorubicin that you actually can see in the tissue. But after 5 minutes and longer, then you don't see almost anything anymore. If you use these liposomes, and then inject them in the bloodstream, then you can see indeed the vasculature, but you do not see the doxorubicin getting out in the tissue. And if you combine the two, the Thermodox, the temperature-sensitive liposome with the doxorubicin together with hyperthermia, then you see that you actually get the doxorubicin everywhere in the tissue. So quite a beautiful example with optical imaging with fluorescence imaging on the effect of hyperthermia and temperature-sensitive liposomes. So you get a minimal doxorubicin uptake in the cells, liposome doxorubicin stays in the vasculature, and this intravascular release leads to high doxorubicin concentration in the tissue. Now, MR guidance of radiotherapy and HIFU. Let me go back to this a moment. We have seen now what effects you can reach, what bioeffects you can have with focused ultrasound, by temperature, by the microbubbles, by the pressure wave. What can you do when you want to assess what have I done with the temperature? In the evaluation of therapy for MR HIFU is the assessment of the ablated volume that can be done by either T1, T2, rapid 3D, using especially rapid 3D MRI. Often, of course, if you do these ablation, the perfusion and the flow holds. So if you can assess what the perfusion is doing, and there are many MR techniques that actually can do that. You can also look at diffusion for ablation. That diffusion is also being affected, so you can use that. And you can use contrast agent uptake for drug delivery as an example of what you can do to show what the effect that you have reached. I don't want to go too much in detail for the time that I still have. Want to go a little bit into detail what we want to do in Utrecht in the future plans here. And there are two main topics that are, apart from the things that I already have told, where our attention, especially in the focused ultrasound side, where they are going into. One is the blood-brain barrier disruption in pediatric brain tumors, and the other one is immunotherapy. The blood-brain barrier therapy, I have already explained what Claire Verheyen, Nathan McDonald, and their teams have done at Harvard and Toronto. This is a project that we want to do as well in Utrecht. We recently acquired the InsightTech equipment, and this year got especially an injection of enthusiasm and also funds, because the Prinses Maxima Center was created in the Netherlands, where all of the pediatric tumors actually will be treated. That's at least the plan. Instead of having each hospital, of each academic hospital, having a pediatric department, that most of this will be done in a single center. And that is actually was built next door to University Medical Center in Utrecht. We have a large project together with the oncologists there, and this is especially with Dennis van Vuurde. This is one of the kids who unfortunately was got a tumor like this one here in the brain stem. There is very little that one can do in this, because there is not with you cannot treat here with radiotherapy nor with surgery, simply because of the location. This child was actually heavily involved in a fundraising event in the little time that that remained to him. He did a fantastic effort to do this. But this shows how serious this problem is, and there has been very little progress over the years on the survival of these children. So they basically almost all die within 1 or certainly within 2 years. This is this helmet that I mentioned before, this InsightTech developed helmet, start of the clinical translation project. This is a study that was a recent study from Toronto, where the technology was explained. Again, this will be, we have the equipment now in Utrecht, and we want to get to the clinic as soon as we can. Another effect that I want to do, and I want to look at, is this immune system modulation. And for this, I just go back a moment to the different bioeffects of the focused ultrasound. I covered already quite a bit heating. I covered cavitation to some extent. And there is one thing here below, the creation of intra-tissue pressure waves, microbubbles by the pressure wave, that I have not yet covered. And that is a technology that we call Histotripsy, or boiling histotripsy. And what is different then to these other technologies? It is that the pressure wave, the pressures at the focal point are a lot higher than you have even for ablation. These pressure waves, when you make them higher and higher, they become, instead of nicely sinusoidal, they become highly nonlinear, and you get these sawtooth type of pressure waves, where the maximum, and if you reach maximum pressures that are basically of the order of above 50 megapascal positive and lower than minus 12 or minus 15 millipascal negative pressure, then you get actually in tissue, you get bubbles formed. The tissue is basically boiling at these very low pressures. It's not that you reach very high temperatures, the temperature is hardly raised at all. But because of the pressure, the very low pressure at the negative part of the wave, you get actually microbubbles formed. And these microbubbles, they basically shear the tissue apart. They just completely liquefy the tissue. Now, and this histotripsy can be used also for special bioeffects, and the one that we have worked mainly with is immune system modulation. And this is what I basically refer to is the work of Avinash Ranki, who did his PhD thesis with me in Utrecht, did his PhD thesis 2 years ago. But he did his work mostly at the Children's National Hospital in Washington, as well as the NIH, the intramural NIH with Brad Wood and colleagues. Now, I want to give you a bit of feedback on this before what is happening here, because what do we want to do here by liquefying locally the tissue? If that's tumor tissue, then what happens there is that you release tumor antigens. You not only release tumor antigens, but also all kind of danger signals and cytokines. And you're influencing there the local immune system, local, but also systemic. And why is that becoming important? It's actually becoming important, especially because of this recent development of the checkpoint inhibitors. So the people got the two inventors of this, Ellison and Hong, and I forgot his name exactly, on the Japanese researcher. They got the Nobel Prize of these two, the anti-CTLA4 binding here and the anti-PD1 and PDL1 that is binding here. So this actually counters the way that tumors suppress the immune system, and by giving this, there is actually quite a spectacular progress in immunotherapy because of those checkpoint inhibitors. These are not the only ones, but these are the most important ones. However, they don't work on all tumors, and especially some, like melanoma, they react quite favorably, but some others don't, where they almost don't work at all. And there's of course a lot of research going on in combining it with radiotherapy, combining it with chemotherapy, and so on. What we did with Avinash Ranki is to combine it with histotripsy, with high-intensity focused ultrasound histotripsy. Now, and this was the model that we use. It's a preclinical model. It's a very simple model. We at day 0, we inject the tumor cells. The tumor is growing, and then at day 1, 3, day 1, 4, and 7, we give a dose of combination of those two checkpoint inhibitors. And this is done on a neuroblastoma mouse model, a model this is actually the pediatric solid tumor that actually give the most. This is the cancer that the solid tumor in kids that has the most victims. And tumor immunotherapy on this in the clinic, it has been tested and it basically not working. Now, if we do this combination here, and this is the work that Avinash published in Clinical Cancer Research 2020. So if you look at these different curves, this is the post-treatment, as is the percent survival. Then basically you can see that in all combinations, the mice died, and they did not survive, and they did not survive. Maybe they survived 10, 15 days. But here there is about 60%, this green curve, and the green curve is the histotripsy combined with the 2 checkpoint inhibitors. So this green curve, there was about 60% survive. So it's not only that they survived longer, they were completely cured. Now, and all of these other models, like histotripsy combined with only anti-CTLA4 or only anti-PD-L1 or histotripsy only, it did not work. By the way, also a little bit of detail, this histotripsy, we treated about 2% of the tumor only. 2% was liquefied, not more than that. So most of the tumor was surviving there, but it was later on, all of the tumor was cleaned up by the immune system. Now, if we did this was in the neuroblastoma model, if we did this on bilateral tumors, we treated only one side, and the other side we didn't treat at all. And you get the so-called abscopal effect. Also here, 60% of the mice were cured. Those, the mice that got cured, they were actually challenged by a double dose of cancer cells in at least 6 months after they got this, after they were cured by this procedure. None of the tumor cells led actually to a tumor. And if you look at those mice and checked the memory T cells and B cells, then these are the surviving, the percent memory cells that we could actually find, the memory T cells. They were clearly, these mice were vaccinated against this tumor. So quite a spectacular result that we are trying to bring now to the clinic. Again, there are, of course, that whether this will work in the clinic, that will be a long-term effort to see if this can be done. Nevertheless, we are going to, with this type of anti-PD-L1, look at, this is indicated here, the primary tumor. This is what is going on in the tumor cells and the T cells. This is here what the lymph node is doing. And what the idea is that the dendritic cells here pick up the antigens from the tumor and bring it to the T cells. This actually, activation of the T cells actually happens primarily in the draining lymph node, and then the activated T cells are being generated, and the T cells then travel to all of the body and will kill any of the metastases or other tumors that are ongoing. These advantages, so these histotripsy, it's a localized and tissue fractionation, but it requires quite a bit from the hardware. It leads to release of tumor antigens and danger-associated molecular patterns, so-called DAMs. It creates a localized and rapid sterile inflammation with release of all kinds of cytokines. It leaves macroscopic vasculature intact, and the surrounding tissue is viable. It has no incision, it's non-invasive. It has not yet been applied in the clinic. We hope that we will be able to start in autumn with the first clinical study on this. This brings me to the end that we are trying to, as we are here in Utrecht, a so-called Center of Excellence from the FUS Foundation, working together with the companies Profound and Insightec, Profound with the histotripsy, Insightec with the blood-brain barrier work, together with the Princess Maxima Center for the clinic, the pediatric tumors, and Isala is for other work as well, and Zwolle, where we have a large collaboration set up. And this brings me to my final conclusions. The MR guidance of radiotherapy and MR guided HIFU will set the next stage in high precision therapy and oncology, but also in neurology. There is a strong synergy in MRI techniques for MRI and MR radiotherapy, motion descriptors, target tracking, continuous treatment planning updates, as well as some unique features like temperature mapping, therapy evaluation. Blood-brain barrier disruption and immunotherapy are early stage but highly promising focused ultrasound application. And there are many people that are part of this. This is the people, mostly those that are working, have worked or work together with me in the at Utrecht on the immune stimulation project and the blood-brain barrier. So with that, I would really like to thank you all for your attention, for your patience as well. And if you have any questions, then let's go. Thank you.
Thank you. Thank you. Thank you very much, Chrit. Yes, we have some questions. Luis Concha is saying here in questions and answers, I enjoy your talk very much. Since the opening of the blood-brain barrier is not specific, can noxious molecules catch a ride along with the drug being delivered and cause secondary effects? Similarly, what immuno-related side effects occur due to BBB opening?
Yes, that's of course a very good question, because the blood-brain barrier is not there for nothing. It has a real function. It's to shield the brain parenchyma from the immune system. So if you open the blood-brain barrier, there is a certain risk for that, and there has been a lot of discussion and a lot of studies on how this can be done. And whether it is dangerous. So work, for example, at NIH from the group from Joe Frank, they have looked at this in detail. Also, the group of Claire Vohininen in Toronto. It appears that if you are very careful with the pressure levels and you don't go above 400 to 500 kilopascal in the focal point, that then any of the side effects that you get are very minimal. Because if you want to do this for drug delivery, you want to do it multiple times, probably in most cases. So let's say if you want to do this 6 or 10 times, it still has to be safe. So early indications, if you are very careful with the pressure, then it can be done safely. Nevertheless, I think the experience with these sort of technologies in the clinic is still very limited, and we should keep a very open mind about any adverse side effects with respect to this. It's certainly a very valid point.
Thank you. Chrit, if anyone has another question, I am checking chat and questions or anyone comments. Someone else? Chrit, I have a question. In this issue about the MR guided technique, or the, sorry, there are more questions. Let me give the chance. Magda Giordano, thank you, Dr. Moonen, for your talk. It is very encouraging to see these advances for the treatment of serious illnesses. Do you think they could be used to deliver neurotrophic factors, for example?
I don't know the size by head of these neurotrophic factors. In principle, I think it should be able to do this. As I have shown this example from previous studies that have been published, you can deliver antibodies in the brain. So it is possible to deliver large molecules. So I think by the same mechanism, I think that neurotrophic factors you should also be able to deliver.
Okay, thank you, Chrit. I was asking you about the technique, and you said that the MR machine itself was modified in the case of the when you have beams, some kind of
in radiotherapy side, yeah.
Yeah,
Yes.
that's producing a beam. And are those? Do you need one of these donut type machines, or this is done in a more generic MR type?
No, these are these modifications on the MRI are actually not very large. And the performance of the performance of this 1.5 Tesla system for the MR-Linac is just basically the same as for a standard off-the-shelf MR 1.5 Tesla MRI. Sorry. So the performance, the gradient performance, the RF performance is all pretty much the same.
Okay. That's quite interesting. So I thought you may need some modification in the main magnet or something like that.
No, these magnets for MRI, it's a standard magnet, but for the MR-Linac, it has to be a modified MRI. Because the magnetic field, the shielding of the magnetic field, again, the shielding is a very well-known thing. MR manufacturers do that to make to make these systems much more compact, and you can so that the magnetic field does not extend way beyond the room where the MR is in. So this shielding of the main magnetic field is a very common principle that all MR manufacturers apply. However, the specifications are different. There, the main thing is to have the external magnetic field, cut that off as fast as you can. Here, the specifications are slightly different. Not only you want to have this external field small, but you want to have it zero where the linear accelerator is, because that's a large metallic structure. And if you have a standard magnet, then because of that large metallic structure, you have induced magnetic fields that disturb even the magnetic field inside the MRI. So you have to work with, it's not a standard MRI, but let's say it's the modifications. The modifications are not that complicated. It's using principles that are very well known.
Perfect. Thank you, Chrit. We don't have any more questions. Unfortunately, we were kind of late due to the beginning and the confusion at the beginning, but we want to thank Dr. Chrit Moonen's participation in our seminar. We are really happy that he had a time and was willing to participate with us. And we are very, very thankful to Chrit, and it was really nice to see you again.
You're welcome. For me too. Thank you, Fernando, and thank you all for listening.